Okay, we will go again ahead and get started. And we want to welcome you all today to the webinar, Optimizing Reproductive Health and Preconception Wellness for Women with Chronic Conditions, Community Research Studios. We'll start with a little bit of housekeeping. First off, let me introduce myself. I apologize, I didn't do that in the beginning. My name is Erica Little, and I am one of the members of the research team. And we'll have a slide to share with all of you, our research team later, but we'll start with some housekeeping. This webinar is being recorded. If you all would please mute your audio and turn off your camera during the presentation. Please share your questions or comments using the chat function, and we will keep an eye on the chat and try to get to those when we are able to. And there will be an opportunity for questions and answers at the end as well. Welcome and objectives. People who participate in this webinar will be able to, these are our goals, describe how to conduct an effective patient engagement in Research Studio, discuss strategies to support bidirectional conversations between researchers and patients, and describe challenges and opportunities for improving reproductive wellness for women living with chronic conditions. And these are the members of our amazing research team. These women have been wonderful, and it's been a pleasure for me, speaking for me, to work with them all, and you will all get to meet them along the way today. So.
Thank you, Erica. Hi, everyone. My name is Sarah Verbees, and I'm excited to see you all joining us today. On behalf of the team, we wanted to offer some acknowledgements. We wanted to thank our funder. So our project is funded by the Patient-Centered Outcomes Research Institute, the Eugene Washington PCORI Engagement Award, and we really appreciate these resources. I also want to thank our patient partners. We know some of you are joining us with the live webinar, and I know others are watching. We couldn't have done this without you. And I also want to read our land acknowledgement for all of us, those who are joining. This is an acknowledgement that we read before we start all of our sessions. And this acknowledgement was co-written with all of our partners. We want to acknowledge that this land is Indigenous land and was first inhabited by the first peoples of this land, our American Indian people. This land was stolen from them. North Carolina is home to the largest population than any other state east of the Mississippi River. North Carolina is home to 8 state-recognized tribes, which include the Coharie Indian Tribe, the Haliwa-Saponi Indian Tribe, the Waccamaw-Siouan Indian Tribe, the Saponi Tribe, the Lumbee Tribe of North Carolina, the Meherrin Indian Nation, the Occaneechi Band of Saponi Indian Nation, the Eastern Band of the Cherokee Indians, and is home to the Tuscarora. We recognize and respect their brilliant gifts and contributions, past, present, and future. They are a living legacy. We want to acknowledge that the United States, including our institution, the University of North Carolina at Chapel Hill, was built by the labor and ingenuity of people who were enslaved. We recognize and respect their brilliant gifts and contributions, past, present, and future. Black Lives Matter. We acknowledge that we work in and live in systems that have intentionally benefited some people over others based on their identities. We pledge to do and be better, to do our part to be true allies for change and repairers of the breach.
Hey everyone, I'm Rachel Aridia. I am one of the members of the research team, and I'm just going to be talking to you a little bit of background about the study and our funder. So PCORI, the Patient-Centered Outcomes Research Institute, has the vision that patients and the public should have the information they need to make decisions that reflect their desired health outcomes. And the mission of PCORI is to help people make informed healthcare decisions, improve healthcare delivery and outcomes by producing and promoting high integrity, evidence-based information that comes from research guided by patients, caregivers, and the broader healthcare community. We are funded under a specific part of PCORI called the Eugene Washington Engagement Award Program that supports projects that encourage active, meaningful involvement of patients, caregivers, clinicians, and other healthcare stakeholders as integral members of the patient-centered outcomes research and comparative effectiveness research enterprise. So what is PCORI's definition? We've just thrown out a lot of terms, so I'll try to break it down a little bit more simply. So CER, or comparative effectiveness research, is clinical research that compares outcomes, including benefits and harms, of two or more healthcare options, and then trying to determine what works best for patients and for which patients and under what circumstances. So, for example, if there are two different strategies for blood pressure medications, which medication is more effective, which medication has fewer side effects, which medication might be better in certain populations, right? And PCOR, or patient-centered outcomes research, is a type of comparative effectiveness research. So patient-centered outcomes research is comparing effectiveness of different clinical care and outcomes, but trying to choose outcomes that matter most to the stakeholders, especially patients and the people who care for patients, including providers and healthcare advocates. So patient-centered outcomes research requires the engagement of stakeholders as active partners in the research. And by sharing their lived experiences and other expertise, the stakeholders help influence the research to be more patient-centered.
Hello, I'm Erica. I'm one of the research team members as well. And for our current work with PCORI, the Optimizing Reproductive Health Project for short, our project goal is to reduce maternal mortality and morbidity by improving reproductive health care research among Black and Native American women with chronic diseases. We know that Black and Native American women with chronic conditions do not receive the reproductive care they need or deserve. With that in mind, our work focuses on addressing three interconnected problems. The first, non-Hispanic Black and Native American women are disproportionately affected by chronic conditions and experience maternal mortality rates 2 to 3 times higher than their counterparts. Second, research on topics relevant to reproductive age minoritized women with chronic conditions and that center their perspectives are important for addressing these disparities. And lastly, minoritized women remain underrepresented as investigators and participants in research, including research relevant to reproductive health outcomes. This image here on your screen represents the culmination of the work from our first project together with PCORI. For that project, we listened deeply to women about their experiences with navigating systems of care. So that's what you see here described on this beautiful imagery. We also learned more about the topics women wanted to be studied, and we also learned about their ideas about how to improve their care. Overall, we gained insights into these complex, yet highly solvable problems. This work that you see here became the roadmap to inform how our team decided to move forward. And now I'll turn it over to Charnette to describe more about this work in detail.
Thank you, Erica. So now we're going to talk about community engagement studios connecting women and researchers to improved care. So optimizing reproductive health project aims. One, convening and support a diverse learning community of patient stakeholders interested in improving research for chronic conditions impacting women's reproductive health. Identifying PCOR approaches for 3 research studies for 3 different chronic conditions impacting women's reproductive health, and launch a sustainable patient-led advisory group to consult with researchers working on chronic conditions impacting women's reproductive health. So in optimizing reproductive health participants, we had 17 patient partners. They all identify as Black, female, Native American, or both. And they all had 1 or more chronic conditions. These women came from across North Carolina and 1 county in Ohio. The chronic conditions include obesity, hypertension, diabetes, kidney disease, cancer history, sickle cell disease, fibroids, endometriosis, and PCOS. Five of the researchers received feedback on their studies. 3 patient partners led a research team, and I think there's a little bit of a breakdown with that. 1 community leader, 3 physicians, 1 public health social worker, and 1 project manager on the lead research team.
Thank you, Shawnette. Hi, I'm Sarah Verbeest again, and I'm going to just talk to you a little bit about the approach that we took for our project. So I think I missed a slide. Nope, maybe not. So this was the cycle that we did 5 different times with our research partners. So we started off having conversations, getting the word out to researchers to let them know that there was an opportunity for them to participate in talking with people with lived experience and getting feedback on the research. So when we finally found someone who was interested, then that researcher met with our team, the folks that you are hearing from today, for about an hour. And we spent time really listening to them about what was the question that they had to, that they would like answered, what did they need to know. And then we spent time talking with them about how they might best engage with the patient partners during the community feedback studio session. Each of our researchers then recorded a short 5 to 8 minute video about the research, and they had a tip sheet to give them ideas about how to do that. It was really important to us that they used very plain language, regular everyday language when talking about their research. And we also asked them to share at least one thing about themselves that wasn't related to their professional life that they'd be willing to share with our patient partners. Our team then, the research team that is doing this webinar, spent time and we continued to craft the questions that they were going to ask in the session. And then we shared those back with the researcher for review. So there was a little bit of back and forth to really find just the right questions to ask during the studio. We also had our group of wonderful patient partners. And so they had a chance to do a doodle poll and identify the date and time that worked best for them. They received the video from the researcher, and sometimes they also received a research article that that researcher might have published. And we reminded them in advance about the studio. So then we did our studio session, which is where we would always create an icebreaker and time for people to check in with each other and connect as people. We always set discussion guidelines for how we wanted to be together in that space. And then we facilitated the questions being asked and a chance for our patient partners to respond. Our sessions were each an hour and a half. And as Shawnette mentioned, we were able to do 5 cycles of this. At the end, we asked our patient partners and our research partners to complete feedback surveys about the session. And then we studied as a team those surveys and what we learned. And the next time we did it, we tried to improve and make changes as we went. This is just an example for those of you that may be interested in the post-studio evaluation questions that we asked our patient partners. It was really important to us that people felt that this was worth their time and that they were able to give feedback. And we were also curious to know if they thought that the researchers were going to take the advice that they so kindly offered. And then we also heard back from researchers. We wanted to know if it was worth their time as well and if the feedback that they received was valuable and what they liked. And we were really happy that the survey responses for all 5 of the sessions were really positive and showed that this had been a generative place. And so to talk more about our results, I'm going to turn it over to our colleague, Sishay.
Hi, everyone. I'm Sishay Harding, and I'll just go through with you the results of our findings. So as Sarah mentioned, we coordinated 5 different studios, and for each we had 8 to 10 patient partners attending and giving their feedback. We had our 5 different researchers, and each of them covered a different topic relevant to women's reproductive health. One researcher focused on fibroids, another infertility, another sterilizations or LARCs. LARCs are long-acting reversible contraceptives, so things like IUDs. Genetic conditions, and pregnancy intendedness. And then our researchers had various methods that they used and that they wanted patient feedback on. And so those included utilization of the electronic health record and insurance claims, help with decision tree support, help with choosing and facilitating focus groups, and then on menstrual blood collection. And as Sarah mentioned, overall the feedback was generally very positive. And it was an iterative approach where as we got feedback, we were able to apply it to the next community engagement cycle. Some patients thought that the researchers would take their advice and apply it, and others weren't so sure. And so we had a mix there. In terms of the patient partner perspectives, so if you look at other, studio cycles, largely there's benefit shown to the researchers. And so researchers might say, I received great feedback, which helped me to improve the quality of my research. It helped me to then maybe acquire a grant or acquire additional funding for this research. But our model was unique in that we focused on the patient experience. And largely patients noted that there was substantive benefit to participating in these experiences. And so they likened it to kind of facilitated advocacy sessions and noted overwhelmingly that it increased their trust in research and their likelihood of future research participation. And so we have a few quotes here. And so the first one is from a patient partner who said, "We have to tell our stories so many times, but nothing changes. This space feels like a place where the stories matter and are heard." And the second quote is, "I felt more comfortable as I heard other people's answers and saw that their answers weren't judged. I found myself with growing trust and spoke up more and more as the sessions went on. Experience can't be wrong." And then after we completed the 5 sessions, we had the patient partners come together with the research team in a debrief. And there we asked them various questions about their experience. And as we talked, we had a graphic artist, a visual approach, who was able to draw to detail and illustrate the themes from that debrief. And so I'll ask a couple of us to kind of just like pick out our favorite points from that project debrief and just talk a little bit more about it or something that resonated with you.
Hey, C-Shay, I'll start. I'm Melissa Richardson. I'm part of the research team and also one of the patient partners. So I was honored to have a dual role here in the project. And this graphic representation, I really, really enjoyed this entirely throughout the project because I really felt like it really brought together so much of what all of our patient partners shared. It also really pulled together in a very unique way the goals of the project, but also just the relationships that developed as a part of the project and the trust that was built as a part of this group in feeling very comfortable in sharing very sensitive experiences and things that folks have been through as a part of their provider experiences. And I felt like it lended very well to our researchers then understanding the sensitiveness and unique needs of Black and American Indian women in being able to really trust providers and be able to serve as partners in our own care versus a more provider-led care experience.
I wanted to touch on the surprises. Um, I was kind of torn between the surprises and challenges, but they kind of go hand in hand. I was able to also be a patient partner as well, on the project. And I really appreciated, just like you saw in the quotes, how open people felt. But understanding that that wasn't easy. Um, the bravery it took, the anxiety that may have been mustered up in trying to share their stories and wondering if anything that they were saying was going to make a difference. It's hard enough to go through what you go through in any medical sense. You go through the challenges that come with diagnoses. You go through the challenge of trying to figure out a diagnosis, but then to talk about the issues that you had and hopefully create a segue for other people to find answers when sometimes we don't have answers ourselves. And the researcher engagement as well, like it went both ways. I think there's the distrust comes from not understanding that the researchers are human too. Um, and so that dynamic came out in our sessions where it's like, oh yeah, wait, they actually, there's a lot of researchers who care, and that's the reason why they get into this work. And so it helped bridge a gap to create more opportunity and hopefully more times like this. And I'm hoping that this goes across, is utilized across research so that people can tie in the ones that are being researched on and the ones that are being cared for.
And I'll just speak to something else that I think was really important, and it's around the comfort in speaking up. And really how we were able to create that hierarchy where it was like level set, right? And making ourselves accessible. And I'm happy I was able to be, I'm a part of the team, but a patient partner as well. And, what we kept speaking about on both sides with the researchers and with the team and with the other patient partners is being intentional in the language and making everyone have a basic understanding of what we were actually talking about. We spent a lot of time with the patient partners and behind the scenes, just challenging each other. Like, if I were to read this as a stranger off the street, would I truly know what this person was saying? If I was a patient off the street and this researcher sent this to me, is this fair to say that we really gave them the tools that they needed to really understand what they were reading and understanding, and then being able to take that information and saying to the patient partners, this is our attempt after many tries of listening to you and trying to share back this language so that you feel empowered when you talk to the researchers, so that this hierarchy that we often fear in these spaces with people who have more knowledge, or there's a power dynamic, you feel empowered that you can ask them questions and feel like, yeah, I can engage in these conversations with confidence. So I wanted to point that out because oftentimes that unspoken power dynamic, even when researchers engage in participatory research, sometimes that part is not invested in as much as it should be. And I'm really happy that the patient partners kept saying, like, thank you so much for challenging us and each other about level setting, so that we could really engage in meaningful conversation.
Yeah, thank you so much, Erica, Sky, and Melissa. Now I'll talk a little bit about the perspectives that we shared as a research team. And so we had another debrief with our research team. And in general, the themes that came up were that, creating a space where patient opinions belong and are valued improves research in general, but it also improves the patient-centeredness of the research. And as a result, this can bring healing and encouragement to both patients and researchers. And it's particularly important for groups who have, historically been harmed by research. And then it also improves the quality of the research. And so there we're getting back to that benefit. So not only, benefit to the patients, but benefit to the researchers. And then we also realized that the diverse, both professional and racial identities of our team allowed us to better engage patient partners and prepare researchers. And so, as you know, our team is composed of both individuals with lived experience as patients and as women of color, as well as researchers. And so by working together, we were able to be a better kind of glue or facilitator for the researchers and the patients. And then lastly, although community engagement studio experiences are delicate and they require intentional care as individuals share their lived experience on super sensitive topics. These experiences have incredible potential to improve the quality of research and build community trust. And so this is a debrief image from when our team met together to talk about our experience. And I just wanted to start off by just reading the banner at the top. So research can be healing and research can be transformative. And with that, I'll hand it over to a few other folks on our team who wanted to highlight certain points.
Hi, I'm Yvette Thompson, and I'm the project manager. And I wanted to echo what everyone else has been saying, but I got to deal with the ladies more on a one-on-one basis. So I got to know them better. And some were shy at first, but then they start coming out of their shell. So it was some challenges, some hiccups, but we couldn't get everybody that wanted to be on it because of the times that we had the meetings. But we had a lot of people interested, and I think everybody shared their story in a great manner for us to make these pretty illustrations. So I thank the ladies. And the team.
I think on this one as well, the come as you are really stuck out for a lot of folks, including myself. We all juggle many things in life, work, family, home, community, things that we're involved in. And so it was also really refreshing to be involved in a space where I could come as I was, present myself sometimes in many different facets. And many of our patient partners that are on with us probably can attest to times where folks were cooking dinner, caring for children and family, caring for parents. So many ways in which we came and we were still valued and heard and seen in that space where we are. And so that was also really important for the group.
I wanted to talk a little bit about when the section that says what brought you here. Some of the elements that worked really well was the size of the group. Even in this PCORI research project, the relationships that are built here creates an atmosphere of openness. I've said many a time to many of the members that I'll feel nervous. I won't want to share on certain levels, but then I find myself sharing way more than I intended to share because I did feel open, and that openness cannot be faked. It just can't be faked. So having not only the come as you are, as Melissa stated, is when you come as you are, you present who you are, people will feel more apt to share. So the small group size is the land acknowledgement. I tend to kind of close my eyes at times because there's a lot happening in the land acknowledgement. I appreciate the energy, the honesty, the heartfeltness of that. Like, I think in many atmospheres, it can kind of feel like, oh, they're giving a land acknowledgement. No, not here in this space. I feel it every time we go over it and appreciate that. And I know that the patient partners see that, hear that, and it gives them that extra sense of, oh, they see us. And then just the communication styles. Like you can kind of feel like in certain atmospheres, you have to speak a certain way. You have to look a certain way, so come as you are. But also being afraid that you will not understand, as Erica touched on, you will not understand what's being presented, or you won't be able to give something that's meaningful. And so because we were able to just hear people as people and not as the titles that they wear, a lot of information was shared, and I think that made this project go further than it could, and that will be very beneficial in any space to kind of take off your hats, and be people and present what you need to present.
And there's only one other thing, and I'll speak to, is we kept saying, this is a challenge, but it's positive. This is a challenge, but it's a positive. And I want to say, I know everyone's like, oh, they sound so kumbaya. We're not really lying about that. Like, we're so serious because we've been working really hard at creating this safe space and acknowledging the uniqueness of folks that come to this table. But I'll just quickly speak on it because he said, do you need to step in? And you tell me, because I'll cut it.
No, I absolutely don't. You go ahead.
I'll cut it. See, this is us doing this. But just importantly, to acknowledge that the researchers at times were uncomfortable with the responses that they got from the patient partners. And they couldn't really hide that because it was in real time. But I want to commend them for walking in knowing that when they were going to engage with us, that they were going to walk into sometimes hard conversation. And that the way that they designed their research study in their mind was not the approach after talking to the patient partners that were best for their work. And, just like artists are sensitive about their work, researchers are artists in their own way, and they're sensitive about their work too. So to be brave enough and to be humble enough to really hear the real side of how patients feel about research and how they would like to be engaged in research was very eye-opening for our patient partners, and they spoke about that. They were very surprised that even when those conversations happened, that the researchers were still open and acknowledged that, okay, I need to reframe this, and that they took that information and absorbed it. So I do think it was important to just highlight that because that is spoken about, but we actually experience it in real time, and we create that space to work through that. So I think that's another important lesson to take away if you do this kind of work with patient partners and researchers.
Yes, I 100% agree. And as a research team, we learned so many lessons about bridging through those nuances. We learned about better preparation. We learned about, better preparation of both the researchers and the patient partners. We learned about how to improve our facilitation when we brought these two groups together so that they could be the most impactful. And there's one theme that I want to pull from this drawing, and it's the one at the bottom right, and it says, the trust we had with each other internally built trust with our patients. And so I think that's how I would potentially summarize our work together as a team.
That's kind of a tough act to follow, but I will try. So for researchers who may be interested in considering a studio, we just have the following advice. So first and foremost, include community perspectives early, because we found that researchers who were at an earlier phase of their research had more ability, even you know, they may have been uncomfortable, but they actually were at a space where they could make changes. If it happens later in the study, they may have already made promises to their funder or made budgetary decisions that do not allow changes. And so just like I know my husband's a statistician, he says, talk to the statistician first, right? It's same thing, talk with the community first if this is desired, because otherwise it may be harder to pivot. We also wanted to say that that will result in research that is patient-centered, right? We talked about patient-centeredness at the beginning. The only way we can have patient-centered outcomes is if we involve patients. It's kind of sounds simple to say, but I feel like I'm in so many spaces where that's not being considered many, many times. And this was just a huge breath of fresh air to be involved in this study where it was kind of flipped on its head. Secondly, I think was already said, research can be healing. I think we all just experienced so many healing moments. At least I did, and I feel like others expressed that as well. And you know, if there's a willingness to listen and to actually make change based on the stakeholder perspectives, then that just builds trust. And for patients who may have had experiences of not being listened to and dismissed and of experiencing harm, they carry a lot of trauma around that history. And potentially, if they're involved in research like this, it could, if done right, offer an opportunity for some healing because they're finally having a voice and being listened to, and potentially help improve things for other patients in the future. We would recommend, please go in with an open mind and a listening heart. I think Erica said it better than me, so I'm not sure what else to say, but it might be uncomfortable, but it will be beautiful. And if you listen and just really see what the patient stakeholders give as a gift, not as something you deserve or need or are going to use, but just truly as a gift. Next slide. So in terms of if you were trying to support a community engagement studio, so for people like us, like our research team and like Tracks, we really recommend being intentional with preparation. This has already been mentioned as well. The researchers needed coaching. I think about this a lot. Like we as researchers and even as healthcare providers, we don't actually get a lot of training about how to interact with communities, right? And that's not part of, like, we get a lot of didactic training, but it's not that. And so researchers can be very smart and expert in their field, but may not be experts about how to talk to communities and need a lot of coaching. We prepared the patients as well. And this was really important because we didn't want them to come to the session like again, like Shawnette and Erica and Melissa have alluded to, especially Shawnette said about feeling like you have something important to say and you know, not having imposter syndrome or feeling like you don't want to share, right? Like, so that patient partners could hopefully come to the sessions really knowing and understanding the research and feel like they really have something to contribute. The sessions really needed facilitation. This was an evolving learning for us, and we shifted our facilitation as we went, because at first we did less facilitation, and then we realized actually we need to provide more facilitation, which is what allowed, as Erica said in the last slide, the trust that we had with each other was able to overflow into trust in those sessions because we were kind of leading the facilitation coming from that space. Definitely flexibility of scheduling and participation. You know, we first began this work in 2020, and so it had to be on Zoom, but we really found that having it on Zoom really enabled participation, especially of reproductive age people who also have a lot of stuff going on in their life, including making dinner and taking care of their pets and their humans and all of that stuff. And I'm sure I was making dinner a few times on the call, responding to multiple, and everybody else was too, and that was super important. Graphic note takers, we've already talked about as well. They're really helpful in portraying complex themes, taking all of our words and emotions, verbal and nonverbal, and putting it into a visual, you know, like that old saying, a picture is worth 1,000 words, but really helped convey the lived experience and provide context. For sustainability, so build on existing patient engagement groups. So this project built out of something that we had established in prior funding, and that was really helpful. But as well, we got a lot of help from Tracks and their experience with working with community engagement. We try to connect and create opportunities for patients to build their leadership capacity. We really try to work on this, and I hope patients, stakeholders, and also the people on our team who provided that lived experience, trying to let everybody do facilitation if they wanted to, everybody write parts of the manuscript if they wanted to, everybody make comments to the researchers about changes or responding to the videos. So just learning how to do that and feeling empowered to do that. And last but certainly not least, patient payment. This is a big one. The university system is not set up to value the experience of the community. And the university in many times shows that lack of value by lack of payment on time, making a lot of barriers to payment, and not just in this experience, but this is something that we all need to work on, and we need to really prioritize. If anybody is going to do this, to really at the beginning start working on how are we going to pay people, how are we going to pay them fairly, and how are we going to make sure they get paid on time. And really trying to nail out those details, that builds so much trust as well, because if we're constantly asking from people who are always being asked for things and not being listened to, and then we're not paying them, or let's just say we pay them $25 an hour, which they could make doing a lot of things that are maybe less vulnerable and hard, that's not going to work. And for us, payment also was part of showing value, because we really wanted to try to make the payments and the incentives something that spoke to them as experts, right? It's not just like the researchers shouldn't necessarily get paid way more than the patient stakeholders, for example, because we all bring an expertise to this, and we're all expert consultants. We just have different backgrounds and experience. Next. So we just wanted to briefly share one other thing that came out of this work is this study that some of us are working on with polycystic ovarian syndrome. So some of our patient stakeholders actually talked about polycystic ovarian syndrome, and it's a condition that really increases the risk of other chronic conditions, and also increases risk of pregnancy, and also just can really affect people's quality of life and their own sense of well-being and all of that. So because of that, this research team was able to start a polycystic ovarian project with funding from HRSA, and involving patient stakeholders from the beginning to co-design the materials. So this is an example of materials that the team has developed for people with PCOS, developed with the engagement of patient stakeholders, and in English and Spanish. And these are all available on our website for examples, but this was just a really great process of learning, like, okay, here's what we want to communicate as researchers or as clinicians. Okay, how's that speaking to the patients? And then also starting with, well, what do you need that we're not communicating? Like, what are you missing? And so this has just been a really fun way to keep moving this engagement that we have. And I will let Melissa take it home. No one better than her.
Oh, thank you. So lastly, we wanted to share this graphic, and at the end, both groups were able to have an opportunity to share hopes and wishes for each other. There was a lot of good energy in that part of the project and the sessions, and folks just expressed such a connection with each other, experiences to support each other, and wish to continue together in this work, because folks just felt how important it really is, and how impactful their voices are in this type of work. And so you see that represented here in the graphic of so many things that came out of this outside of just our research goals. We also want to just say thank you to everyone, our research team, our patient partners. Thank you for joining us, folks who are on today listening, and those who might listen in the future. We want to say thank you for sharing your feedback, your thoughts. And we do want to, at the end of the slides, it has some information of how you can connect with us, email, Facebook, Instagram, and phone. So please continue to connect with us. We do want to take a few minutes to open it up for any questions that anyone has at this time. So I will heed the floor to any questions.
I have a quick question. Who's doing the graphics? Who's doing like the with,
graphic representations?
yeah, with all of our thoughts and
Yeah, we had a graphic artist. Sarah, I'm sure you can share that that name, but we had a graphic artist that a visual approach. There it is. Yep, a visual approach is the name of that company. Yeah.
it's
And they were amazing, as you can see in those graphics that were shared.
yeah.
Wonderful way to capture thoughts, feelings, reflections, in such a beautiful way. Absolutely my favorite part, besides participating with you all. Any other questions? Okay.
I want to just thank, we have a lot of our patient partners that have listened in. And so I don't want to put you on the spot, but I want to create a space if there's anything else that you might want to share before we close. So we aren't going anywhere. So we are going to stay connected and continue to look for ways that we can work together. I also want to thank the NC Tracks team. Simone is on, and EC, for facilitating and for all the advice that you all gave us across this entire process. We really appreciate it. It really made a big difference. And to everyone on this screen, this is definitely continue to work together, to continue, as we like to say, to keep the band together. We appreciate all of the researchers and folks that took time to listen to this and watch this, and we would encourage you to give this a try yourself.